All right, so exam three review, PNR 205. I'm going to share my screen. I PowerPoint up. All right, can y'all see my screen? All right. So, oops. Did everybody do their oh my gosh, what's it called? Their review packet? My mouse is
Yes.
acting crazy. Okay, here it is. Nope. Hold on, give me 1 second. My mouse is acting a little insane right this second. Can't even find my mouse. I think my battery just died. Okay, I think it did. All right, can you see can you see the PowerPoint? We'll start there because I don't know what's going on with my mouse.
Yes.
All right, cool. All right, so we will start. Um, I really need my mouse to work. I think it's working over here, but it's not working where I need it to work. Give me 1 second. Okay, did you guys lose the PowerPoint?
Yes.
All right. I had
Yes.
to get my mouse is working again, so I had to sorry about that. All right, we'll start again. Here, let's do that. There we go. All right. Sorry. Again, sorry, I don't know why all of a sudden my mouse just decided to not function appropriately. All right, so exam three is going to cover the last part of chapter 17, chapter 18, chapter 5, 13, 15, and 16. Um, so go ahead and I'm going to also, I'm going to pull up the concept review. So I'm not going to follow the outline. I'm going to follow the PowerPoint. So it starts with our nursing theories. So we have Maslow's hierarchy of needs. So tell me about Maslow's hierarchy.
It's basically our hierarchy of needs, what we need to accomplish in order to move up. So our physiological needs, our vitals, eat, sleep, poop, sex, reproduction, and then our safety and comfort, like housing, our love, like our connection with people, and our self-esteem. And then the top one is self-actualization, like knowing who we are as a person and feeling good in that and having our peers respect us.
Very good. Awesome. So basically, right, he said that all of these needs are common to all people, right? That internal, external, physical, as well as psychological needs are common to all people. And he arranged those in a nice little hierarchy for us. Unmet needs create tension, right? Which motivate the person to react to meet the need, right? So, starting with the basic needs, if I don't have shelter, right, then that's an unmet need that's going to motivate me, right, to try to find shelter. Same thing, food, clothing. And then once those needs are met, right, we're no longer aware of the need. And so it's not a motivating factor anymore, right? So that again, anything that is unmet is going to cause a motive, it's going to motivate them to try to meet that need. Then we had Leninger. Leninger's was her cultural care theory. And so with that cultural care theory, we have two kinds of care, right? We have our generic and we have our professional. Generic is our home remedies that we use in care. Professional, right? Those are provided by specifically trained people that provide that care. There's three modes to providing that care. We had the preservation or cultural care preservation or maintenance. Um, and so this means that we're assisting people of particular cultures to maintain their care values that help them to maintain health or to restore health, right? So, keeping, using some of their cultural practices, right, as part of their care. The cultural care accommodations or negotiation. This is showing alternatives that are safer. Um, and Vicks is always a big one. I love Vicks. I don't know if anybody else does Vicks. I love the smell of Vicks. It works really good. Um, but it should not be placed in the nostrils. And so, telling that, having them place it on the chest or the neck, right, and rubbing it in is safer than placing it in the nostrils, right? I don't know if anybody's that I've done it before accidentally, but it can burn too. I don't know if anybody has ever experienced that. So, right, just providing a alternative, safer way to include their cultural practices. Um, and then repattering or restructuring. This is respecting their cultural difference while maintaining safe and protective environment. And so this is, if there's a practice that they are using that is unsafe, then providing that education on how to avoid using that practice and then providing another way of doing things that is a little bit better for them. Then we had Hildegard Peplau and her interpersonal relations theory. Um, and so her theory is used as a way to develop a therapeutic relationship with clients. Um, and so there's four overlapping phases of Peplau's theory. The orientation phase is where we help the client to recognize their problem, which also helps to develop personal and social growth. Identification phase. During this phase, the client understands the situation and responds to the nurse who is providing the help. The exploitation phase is where the client begins to depend on the nurse and uses the help that is offered, exploring all possibilities. And then during the resolution phase is where the dependent behavior is given up and the therapeutic relationship ends. Then we had Dorothea Orem and her self-care deficit theory. Um, And so it's a general theory. It has three subcategories, three sub-theories. Self-care. This is a goal that's directed towards a safer environment for life, health, and well-being. Generally speaking, we learn how to respond to health cues, right, in ourselves, or the environment as a way to maintain our health. A self-care deficit, people or personal care doesn't meet therapeutic self-care demands. So we don't recognize or know what to do regarding a personal health situation. So anybody entering healthcare, think about it. You go to the emergency room, you go to the doctor's office, right? There is some sort of a self-care deficit, right? Otherwise, we wouldn't be seeking healthcare, right? Because we don't know, we don't know what to do in a certain situation. The nursing system, nurses empower clients through relationships to help them meet their self-care needs, right? So we respond to them holistically. Um, and help them to meet their self-care needs. So whether, somebody gets sick, they're in the hospital, right? We're the ones that are going to choose the interventions that have, the desired outcomes for the client, right? So things that we do, the care that we provide, the education that we provide to our clients can help them, right, throughout their care process. Then we had Rosenstock's health belief theory. Um, and so the Rosenstock's theory tries to explain why a person or why not a person will take action to prevent or detect illness. And so perceptions may vary. They may have no basis in reality. Their beliefs are connected to existing barriers, like whether it's, they may not see the value in the treatment or the prevention activity. It could be painful, it could be inconvenient. Um, and the fewer negative aspects, the possibility of doing something is greater. So if we can try to remove the negative aspects, right, the inconvenience, the painfulness, the expense, right, then person is more likely to, um, take part in the preventative treatments. And then the last part is a cue to action is necessary. Um, the cue, think about how do we reach patients? Somebody in pain obviously is going to go seek healthcare, right? Because they want the pain to go away. I mean, that's, generally a good concern. But it could be they saw something on TV. They saw a commercial or a billboard, or, somebody from the provider's office even called them to, check in on them to see if they actually will then, and, be like, okay, well, maybe I need to go take care of the situation or do something about this. Um, and so that theory or Rosenstock's theory is really good when we're looking at health promotion techniques. And then we went into critical thinking. Um, and so tell me, what is critical thinking?
Critical thinking is when you're able to think outside of the box as far as a bad situation goes. Like, say, for instance, you're having to put all of your judgment into place to make sure the patient's stable, you have to judge the outcome of what it could be, whether it's going to turn bad or before. You just have to kind of look at the bigger picture as far as critical thinking goes.
Okay. Okay. So that was good. Um, so the process of critical thinking. All right. So when we look at the processes, critical thinking process is based off of our nursing process, right? So data collection, right? So it's purposeful, informed, outcome focused thinking that requires careful identification of problems, issues, and risks, right? So when we are gathering our data, right, then what do we do with the nursing process? We take that data, right, and we sit down and we look to establish nursing diagnosis. And then we move into that planning phase, right? So during the planning with critical thinking, we're going to use our knowledge to tailor approaches based on circumstances, just like with our patients. We gather the data, um, we sit down. What are we going to do with the data that we gathered? What are the needs of our clients? Um, and then we're going to establish our goals, right? And determine what our interventions are going to be. So implementation is logic and intuition. It's based on knowledge, it's based on skills, it's based on experiences of the LPN. And we critical thinking or the implementation is guided by professional standards, right? And then we always go back and evaluate. So evaluate, reevaluate, self-correct, strive to improve. So here's it kind of broken down a little bit more. So that critical thinking, we collect the data in an organized way, we verify the data, we look for gaps or rearrange the data, we look for gaps in information, analyze it, and then we test it out. How do we verify data? So if you're working with a client,
You just
go
ask
back
them
to
the questions.
you can ask more questions. What else can you do? Compare notes, right? Look back at
Yes.
the chart, look at their history, that kind of thing. Yep. Our cognitive thinking levels, right? Our knowledge, our comprehension, our application, and our analysis. Remember, your knowledge is your recall, memorization, right? Your 12 cranial nerves. Um, what else? Your normal parameters for glucose, your normal electrolyte levels, right? Those are all things that you've memorized over your time in nursing school, that you should be able to recall. Your comprehension is understanding what's important about, you know, um, when you look at normal glucose levels, right? What's so important about maintaining normal glucose levels? Application is use what you know, right? So what does that mean to me? What does that mean to my client? And then analysis is breaking down that complex information into basic parts. So here we go. So knowledge would be that normal potassium levels are 3.5 to 5 milliequivalents per liter, right? That's an electrolyte level. You've had that in multiple classes throughout your time in nursing school, right? So it's something that you've memorized. Comprehension, what does it mean if our client is low or high? So hypo or hyperkalemic, right? And then application, what do you do with the information? How do I care for your client? What do we do if the potassium levels are low? What do we do if the potassium levels are high? And then how does what I do impact the client overall, right? So what if you choose to ignore the fact that they have low hypo or low potassium levels or high potassium levels, right? How does that action impact my client? Then we looked at formulating the clinical question. Um, so this is, think about it, and I know I said this in class, right? Always have that questioning attitude. New nurses are going in with new, fresh eyes, right? So you're seeing things from a new perspective, so to speak. So when we look at formulating that clinical question. You want it to be objective and concise. Um, and then you want to use your professional resources, the most relevant research evidence pertaining to your clinical question. Remember, with your resources, most relevant evidence, it's usually within 5 years, right? And making sure that the information that you're looking at is, pertains to the clinical question. And then an expert or a panel of experts will conduct a systematic review. So basically, what this means is you get your clinical question, whatever it is. Why is hand washing important? Whatever your clinical question is. All right. Um, and you want to get the resources. So you can use your online libraries, you can use online journals, whatever it is that are pertinent to why hand washing is so important. All right, and you're going to get all the studies together, and then the panel is going to look at the studies that you've collected and do a systematic review. And all that is a summary of the studies. Um, And then guidelines are determined, um, and guidelines are specific recommendations that are derived from the summary of those research articles. Okay, so let's say, I know this is kind of out there, but let's say you have 30 research articles and 20 of the 30 research articles say to scrub your hands for 30 seconds instead of 20. Okay. Right. So that's kind of where we're going to determine the guidelines. Does that make sense? So you're going to look at all the best practices and then you're going to determine the guidelines. Um, and using your critical thinking skills, the gathered evidence is combined with clinical experience as well as client preferences to use in a specific clinical situation. So use hand washing because it's just a basic one. But it really just kind of depends on what the question is that you're looking to answer. And so, with that, the three components of your evidence-based practice are your best practices, which is your research that you've done. It is your quality patient care, your evidence-based practice, your nurse's clinical experience, and the patient preference. All right, so remember that, there's always going to be those components. So, again, it's best research evidence, your nurse's clinical expertise, and your client preferences. Then we have our two different types of research. So what is the difference between quantitative and qualitative?
One can be measured and the other one is like data collection.
Very good. That was perfect. Yep. So quantitative, right? We have a variable, right? So usually, or we have variable as the event. So we usually have two variables, and you're absolutely right. It's measurable, right? So we are collecting numerical data, um, and we can use statistics to measure that data, right? So quantitative is objective. Your qualitative is your subjective, right? Oops, that didn't move. So data here is collected through interviews or even through direct observations. Um, and, so we can look at what we observe as the client responds, and then the narrative description from the client, right? What their view is. It also could be as a result of surveys. So it's more of a subjective, right? So quantitative, we can measure, it's objective. Qualitative is subjective. It's really not measurable, right? We are getting basic, people's thoughts, people's experience, through your qualitative research. Um, and then we jump into your role as a LPN. And so this chapter, there was a lot of information about things, your roles as future nurses or LPNs within the healthcare system. Excuse me. And so some of the primary responsibilities of LPNs, their first line managers in long-term care or in nursing homes, right? Charge nurses, unit managers, assistant director of nurses. So you guys are in charge of your clients as well as your UAPs. And so under the direction of the RN, you will prioritize their needs. You're also, like I said, responsible for care given by the UAPs. So goal is to direct, to guide, and to supervise them. The spirit of inquiry. Um, oops, there you go. This is kind of goes back to what I was saying earlier, right? You guys are new grads. You've got a fresh set of eyes going out into practice. So always have that questioning attitude. What can we do better? How can we do it better? So the goal here is to raise questions. challenge tradition. Don't accept we do it this way because it's always been done this way, right? So challenge those existing practices. Think outside the box. Look for some of those creative approaches that could be, potentially effective in providing care. So I know I talk a lot about long-term care. When we look at, I think I was talking about fall prevention in long-term care in class, right? In the hospital, there's bed alarms, there's side rails, right? There's all these tools that help keep clients in bed. Not that they're always effective, and I'm not saying that people don't fall in the hospital because they do. But then you go from that, you can go into a long-term care environment, right? There's no bed alarms, there's no side rails, right? So how do we keep our clients safe? And so, sometimes it is really kind of reaching and, thinking outside the box to try to keep them safe, and preventing falls, being very anticipatory of their needs. But look at, deciding, trying to find some of those creative approaches. Then we went into the different types of healthcare settings. Um, so talked about public versus private healthcare agencies, different types of hospitals, and then even some of the other types of healthcare outside of the hospital setting. So when we look at official government healthcare agencies, remember these are supported by tax money. Their primary services are disease prevention and wellness promotion. They provide direct services of healthcare. They're accountable to taxpayers and the government, and they carry out both mandated and non-mandated programs. So some of our official government agencies are like your local health department. So the local health departments are funded by local tax money. They can be subsidized by the state as well as federal levels. They carry out state laws which are mandated concerning community health. They also carry out some health promotion activities which are non-mandated. They will respond to community health outbreaks or needs in conjunction with other government agencies, like, think of things like FEMA or the CDC, that kind of thing. Each state has a state health department that is funded by state tax money. Sometimes we'll receive money from the federal government as well. And then the federal or the national level, which is your Department of Health and Human Services. It is federally funded by federal taxes. And the person who is in charge of the Department of Health and Human Services is appointed by the President of the United States. So with the Department of Health and Human Services, it does have 11 operating divisions. And so some of the ones that are under here would be your U.S. Food and Drug Administration. So the FDA ensures that food, human and animal medications or biological products or medical devices, electronic devices that emit radiation are safe. Um, the Center for Disease Control and Prevention provides leadership in health prevention and promotion programs. It also responds to public health emergencies. And then your National Institute of Health, they fund biomedical research, not only in their own labs, but in, other, colleges, universities, hospitals, other institutions. They also train new researchers, promotes collecting and sharing of medical knowledge. Um, and then we had our non-official or our public healthcare agencies. So our non-official, they are supported by voluntary contributions, as well as fee for services. Their primary service is research and education. They are accountable to their supporters, their board of directors, and their programs are determined by supporter interest. Your private healthcare agencies, um, these are fee for service, so the services must be paid for. The programs are determined by the goals of the organization, but the primary service is curing diseases. Um, it also may provide some wellness as well as disease prevention programs as well. Your teaching and research hospitals, these can either be community or federal government hospitals, are also training centers for healthcare professionals, so nurses, doctors, right, other members of the healthcare team. They treat clients with serious or unusual conditions. They conduct research, development, new treatments. They do um, the clinical trials, sorry. And then they always are almost always affiliated with medical schools. And so they have access to highly trained practitioners, skilled practitioners. Our nonprofit community hospitals. These are operated by community and religious organizations, right? So I talked about like Shriners Hospital or St. Jude's Children's Hospital. They provide short-term inpatient care for acute illnesses and injuries, but they are dependent on gifts and donations in order to supplement their income. Now they'll still bill insurance and things like that, but they do depend on gifts and donations to supplement that revenue. The responsibility rests with the Board of Trustees. Um, but they do, and those board of trustees are usually voluntary. But there is usually a paid administrator that operates the hospital. Trying to think, yeah. Then we have home health. So home health can be public or they can be private, but they provide home health services supervised by or directed by the RN. And then nursing services are provided by the LPN under that RN supervision. In order to qualify for home health, the client needs to be homebound and have a skilled need. Um, and so they can, to get skilled nursing, physical therapy, speech therapy, occupational therapy, um, respiratory therapy, um, but again, the skilled nursing services are provided and directed by the RN, and then the basic nursing services are provided by the LPNs. And so, of course, it's going to depend on state regulations as well as the agency policy, but that will determine what the LPNs can do. But the goal is to achieve the highest level of functioning for the clients. Skilled nursing. So again, in order to qualify for home health services, they have to be homebound and they have to have a skilled need. All right. So it's medically necessary care to improve health or maintain or slow decompensation. So patients that have had a major surgery, that need IV medications, that have severe infections or other health issues, or even your post-stroke patient. So again, in order to get home health, they have to be homebound and they have to have a skilled need. So treatments are giving injections, glucose monitoring, ostomy care, wound care, oxygenation, respiratory care. Those would be some of your home health, skilled nursing, requirements or needs. Primary duties, as a LPN in home care. Remember the RN does the initial education, but LPNs can reinforce, supervise and prepare medications. They can give injections, monitor glucose levels, help the clients to create a safe environment, right? So you go in, you look around, what are some things that we can fix? Um, and then your ostomy, your wound, your bowel bladder training, oxygen respiratory care can be provided by the LPN. And then we had hospice and palliative care. Um, and so there is a difference between hospice and palliative care. So hospice is the goal is to maintain comfort as death approaches, right? So we consider death with dignity. And so hospice or end of life services, they need to be certified as terminally ill, right? Usually within, 6 months. Hospice can be provided anywhere, honestly, inpatient hospitals. There's home hospice care, there's hospice homes. It can even be provided in a long-term care setting as well. But again, they have to have a terminal diagnosis, usually 6 months or less to live. Palliative care is comfort care. It's initiated at the onset of treatment. It can be accessed at any stage of illness, whether they are terminal or not. Um, and so remember with palliative care, they also may still be getting life-saving treatments. Whereas with hospice care, generally speaking, any life-saving treatments are no longer being considered. Um, what else? That's pretty much hospice and palliative care. Um, then we had wellness centers. So wellness centers, the goal is wellness promotion. So they may do nutritional counseling, there's exercise programs, there's stress reduction, weight control may also be another one. I was listening to a commercial, because I think it's over. I think it was over today, or I don't remember. Anyway, I'm not there yet, but I was listening. There's a commercial about the Medicare enrollment for the year. And they were talking about, some of the different plans that are available. And some of them actually will offer, what is it like? I guess gym memberships, I guess is I don't know if that's the right word. But like, for like Planet Fitness, I don't know which ones they offer, right? But you can get a free fitness measurement with some of your insurance plans, especially for the elderly. Because we keep them moving, right? That helps to prevent some certain things. So I thought that was pretty interesting that the insurance companies would actually even cover that. So, but yeah, wellness centers are there's a lot um that can be offered. And even sometimes too, they'll hire nurses within those wellness centers to help provide care as well. Community health services. Um, and so these community health services are best for clients that need education. All right. So these could be community groups. Um, like, I don't know, maybe they have like I don't know, just throwing something out there like a hypertension support group or something like that, right? Um, it also helps with screening and early disease detection, right? Because we know that the earlier that we identify, right, the better the outcomes will be. It also focuses on prevention of disease. So kind of goes back to your community class, right? So some of the community health nurse roles are advocate, caregiver, care finders, health planners, occupational health, your school nurse, if you're a member community, right? All of that good stuff. And so this can be in your outpatient service or outpatient clinics, your HMO clinics, your freestanding private services, right? So a variety of places where we can find community health. Another potential, to hospital or another potential alternative, to inpatient or even institutionalization, is your adult daycare. All right, so adult daycare is pretty cool. And this is for people who still live at home. They may live with family or friends, and they, have care that is, or they have assistance in the evenings and on the weekends, but they don't have it during the day, right? So they live at home, they go to, day or night care. Most of them is daycare. I don't know. I don't know any in my area that has night programs. But generally speaking, again, they live at home. They just need some help during the day, so they go to daycare. Um, let's see. Then we had our funding for healthcare, which was chapter 16, I think, was funding for healthcare. So, how is healthcare paid for? Um, so we had the Affordable Care Act. And so, one of the purposes of the Affordable Care Act was to minimize cost barriers, to improve affordability and access of healthcare, to especially those that are underemployed, uninsured, or underinsured. The primary focus was the prevention of disease. Some of the benefits. It has decreased the number of Americans that are uninsured. We still have some that are uninsured, but it's definitely decreased the amount. It's eliminated lifetime coverage limits. It's reduced prescription drug costs for Medicare beneficiaries. And it also prevented exclusion based on pre-existing conditions. Our health insurance terms. Um, and these sometimes would get a little bit confusing. So your premium is the monthly fee that you pay for your health insurance company or coverage, right? So usually through your employer, or if you went through the clearinghouse, it's how much you have to pay every month just to have the insurance. The deductible is your yearly amount that you pay out of pocket for health services before the health insurance policy will begin to pay its share. So when you're looking at, what health insurance do you want to have? Um, you want to look at your deductibles. You also want to look at your copays and your co-insurances and make a decision from there. So, if it's $3,000, that means if your deductible is $3,000, that means you have to spend $3,000 before your health insurance will pick up the rest. And that's on top of your premium. So it's not separate. All right. So you still have to pay your premium every month. Your copayment is how much you have to pay when you go to the doctor's office, when you go to get a prescription, when you go to the emergency room, right? Usually you'll have that information, like it may be like $25 for a doctor's visit, $50 for a specialist, $200 for an ER visit, whatever. It's gonna vary. And then your prescriptions are also on a tiered, so there's usually like level one, tier one, tier two, and tier three. And so your copay for your prescriptions is based off of what tier your medication is. And then coinsurance is how much you have to pay after your deductible is met. So your deductible is $3,000, you met your deductible, and now your insurance is covering, but you're still going to have a percentage of that you're going to have to pay. And it's like, why have insurance sometimes? I'm just kidding. No, insurance is a good thing. Then we have our public health insurance. So public health insurance is like your Veterans Administration. So the Veterans Health Administration meets the needs of vets. So they have hospitals, they have outpatient clinics, nursing homes, domiciliaries. Then we have Medicare and we have Medicaid. So start with Medicare. So Medicare was added to the Social Security Act in 1965. It is a federally sponsored entitlement program and public health insurance that finance healthcare for all persons older than 65 and their spouses who have had at least a 10-year record in Medicare covered employment and are a citizen or a permanent resident of the United States. So again, in order to qualify for Medicare, you have to be a citizen or a permanent resident, and you have to have paid into Medicare for at least 10 years. It also covers younger persons with disabilities and people that have end-stage renal disease. No person can be denied coverage based off of past medical history. So again, if you're a permanent resident, you're a citizen, you paid in for 10 years, then you are guaranteed coverage under Medicare. There are different parts to Medicare. There's Part A, there's Part B, there's Part C, and there is Part D. So Medicare Part A, that's your hospital insurance. It covers your inpatient hospital stays, your skilled nursing facility stays, hospice care. It also may cover some health, some home health. Your Medicare Part B, that's your medical insurance. It covers most, healthcare provider services, outpatient care, medical supplies, trying to think of preventative services. So like emergency room visits, your mental health services, your labs and x-rays, ambulance services, your durable medical equipment. So like you need a wheelchair, you need a walker or a hospital bed, the kidney supplies, the diabetic supplies. I'm trying to think of what else. And then Part C is the Medicare Advantage plans that those are offered by private companies that contract with Medicare. They can be HMOs, PPOs, fee for service, special needs plans, medical savings account plans. With Medicare Part C too, some may offer prescription drug coverage as well. Um, and those are a lot of the commercials that you probably heard on TV, and the radio coming, as we get into like the Medicare enrollment period. And then Medicare Part D is the prescription drug plan. Um, and it's, offered again by insurance companies, and other private companies that are approved by Medicare. There are costs involved with the other parts to Medicare. Medicare Part A is the only one that you are guaranteed to get. The rest is going to be, um, oh, I went ahead, is going to be out of pocket costs. So again, here I talked about this. These are what Medicare Part B covers. Um, and then there's Medigap, um, the Medigap benefits. Those are, because Medicare doesn't cover everything. And so we do have the Medigap that you can purchase. It's private supplemental insurance in addition to Medicare that helps to cover co-payments, deductibles, co-insurance, and limited coverage situations as well. Again, these are sold by private insurance companies. Then we have our Medicaid. Um, and so Medicaid is, this was also added to the Social Security Act in 1965. It provides medical assistance for eligible families and individuals with low income and resources. It's a cooperative venture, so it's jointly funded by the federal and state government. The federal government just gives broad national guidelines for Medicaid, but each state establishes its own program services and requirements, including eligibility. So you may live in one state and you're eligible for Medicaid, but if you move into another state, you may not meet their eligibility requirements. Um, but this is, for again, it's our low income, low resources are those that are available for or that are eligible for Medicaid. What else? Like I'm forgetting something. Um, Then we have CHIP, which is your children's health insurance program. This is a program that is covered under Medicaid. It provides free or low cost health insurance for kids up to age 19. And so if you remember from community last term, um, then think about the uninsured, some of the characteristics. They lack access to health care. A lot of them will use the emergency departments for reasons that, they shouldn't need to use the emergency room for, but it's usually because of a lack of having a primary care provider. They also more likely to seek treatment during the later stages of illness, which is going to increase their costs. So, think of like hypertension and certain, even cancer. Um, the earlier that cancers are identified, right, their treatment is best. They're more likely to be cured in those early stages. But with our uninsured, because of the lack of access to healthcare, they're generally diagnosed later in the disease, which increases the cost for treatment. Um, and they also may have access to an employer health plan, or the health plan is too costly. So let's just throw this out there. So, if you have a job that only pays, $12 an hour. So what is that? So 12 times four, that's $480 a week. And then I can't do math that quick, but that's not a lot of money. All right. So let's just say you're making $480 a week, but your insurance is going to cost you $200 a week through your employer. All right. So that leaves you with like a $200 paycheck. All right. That's, how are you going to support your family? Keep a roof over your head, all of those things. Hopefully that's not a realistic example. However, I'm just throwing that out there. So they may be employed, but they just can't afford to have the health insurance through their employer, right? So those are some characteristics that you may see. Other parts of funding, we had the prospective payment system, and that's your system of reimbursement that pays a predetermined fixed amount for a service, regardless of the actual services provided, right? So this is where those DRGs come in, excuse me, this is where the DRG system comes in. So there's a formula that the government uses, um, that for whatever disease process, this is how much the hospital is going to get reimbursed. So somebody comes in with a heart attack, they have a formula that they do, and they're going to say, okay, this is how much you're going to have. This is how much you're going to get for care for that patient. So the hospitals will receive a flat fee for each client's DRG category, regardless of how long they stay in the hospital. So whether it's 2 days or 20 days, they're going to receive that flat fee. And so the goal is, for hospitals, they have that incentive to treat clients and discharge them as quickly as possible. And so we see a push to get them in and get them out. If they have to keep them longer, then, and they're not going to be able to get any more money based off of their GRG, then that hospital has to make up the difference in the cost, right? So it can be good in some ways, but it also, can be bad because, they're not going to get the reimbursement for it. At the same time, um, if something were to happen, they get a pressure area, they develop a healthcare associated infection, right? They're not going to get reimbursed for those services either. Um, so your DRGs, it's a category for illness. The fee is based on the category. It's a math formula. So I covered that. All right. Um, So, how can LPNs contribute to improving healthcare? So, talked about a little bit about this, right? Having that questioning attitude, right? Looking at things from a new set of eyes. But other things, participating in continuous quality improvement, following the aims of the Institute of Medicine for improving quality in healthcare, and of course, doing your continuing education, obtaining your certifications. Then we also had never events and sentinel events. So, never event is a medical error that is clear to identify and prevent, but the consequences can be serious to a patient. Whereas sentinel events are events that start as a never event but leads to a patient's death, permanent harm, or severe temporary disability. Oops. And that brought us into our national patient safety goals. So we talked about these. I know we talked about these in class. Um, so your national patient safety goals are they're designed to try to, I don't know if you guys remember, I talked about this in class. I talked
Um,
about, go
I'm
ahead,
sorry. I'm sorry. I didn't get the never event very well. Please.
the never events.
Yes.
So never events are obviously things that we are trying to prevent from occurring. So in class I talked about it. Um Back in 1999, I want to say, the Institute of Medicine they did a study. It was called To Err is Human. And they looked at the number of people that were that were dying as a result of medical errors. And it wasn't, a lot of it is medical, or medication related, but think about like your, wrong site surgeries and other things that have, um, so they're trying to just, um, we're finding ways to do it, but never event is a serious, preventable, and defined medical error that should never happen. Okay. So a wrong site surgery, you gave the wrong medication. That's a never event. A sentinel event is an unanticipated event that results in death or serious harm to a patient. So um, let's see. Trying to think of I'm trying to think of a good one. Um,
Can I ask, so would that be like, say you gave a patient like an indwelling catheter and then they got a hospital-acquired infection and they got like polynephritis, which caused sepsis, which caused death? Would that be never?
okay, yeah, that would be a sentinel event.
No, wait, something like that.
Yeah. So a never event would be a wrong site surgery, giving the wrong medication, um, giving the wrong type of blood. It's something that's serious and preventable, okay? Um, whereas your sentinel event is an unexpected occurrence. So your Claudia example would definitely be
Oh,
in a sentinel event. Does that make sense now,
yes,
Ernestine?
yes, it
Okay.
does, yes.
So your national patient safety goals for long-term care, improve the accuracy of resident identification, improve the safety of using medications, reducing the risk of healthcare associated infections, reducing the risk of resident harm resulting from falls, and preventing those healthcare associated pressure ulcers. For your hospital national patient safety goals, oops, accuracy of client identification, improve effectiveness of communication, improve safety of using medication, reduce the harm associated with clinical alarm systems, reduce the risk of healthcare associated infections, identify safety risks in clients' population, and oops, a universal protocol for preventing wrong site, wrong procedure, and wrong person surgery.
Can I ask,
Oh,
I'm
go
sorry,
ahead.
who oversees that? Is that just like a hospital-based thing?
The national patient safety goals.
Yeah, is that just a hospital-based thing, or is there like an agency or something that oversees that?
You've never heard of them before?
No.
Really?
Yeah.
Okay. No, it's a government. National patient safety goals are, well, not, I guess not government, but it's set by the Joint Commission. So
Oh,
Joint
okay.
Commission
That's what
is,
I was asking, like who makes
yeah, Joint Commission.
okay.
It's a quality and patient safety improvement program that was established by the Joint Commission. It was established back in the early 2000s. And um, a lot of the goals are the same, but they do change. And so if you ever Google it, if you ever Google national patient safety goals, so just like you see here, there's some for long-term care, there's some for hospitals, there's overarching, and for each area of nursing, there are, or for each area of healthcare, geez, there are like separate goals that are listed.
Okay, thank you.
Of course. Um, networking, talked about networking, um, positive actions, right? So networking helps you to investigate benefits of the organization. It also, huh? Oh, helps you, with problem solving. But some of the things that you want to do, again, assist without being asked. If you're sitting and you see your CNAs, your other nurses, or other team members that are struggling or running behind, offer assistance. Having a good cohesive team that's built off of collaboration, cooperation makes the day better, right? It makes things function better. It makes it a better place to work. You know that your patients are cared for. accurate communication. And I know we've talked so much about communication in this class. But communication is so much a part of what we do. And being able to effectively communicate regarding your clients, even yourself, is a huge part of what we do. And then participating in committees. Like I said, you can do quality improvement. There's other committees within the hospital. Sometimes you get asked to join or you get asked to join committees. Other committees are, volunteers. And so you can always ask like your supervisor, your mentor, your manager, like what committees are available. For you to join. That helps you to network within your organization. And you never know, you might find your dream job as a result. And then we have our resume, which is the last little part. Again, 2-page max, 1 page is best. You want to use, quality paper, white or off-white. You don't want any like brightly colored papers. Arial or Times New Roman. Always use spell check. Have somebody proofread your resume. That's also key. Make sure the space is balanced. You want to add, emphasize your strengths. You can use keywords or bullet points, which is fine as well. And then include a cover letter to emphasize your academic as well as your clinical accomplishments. So it kind of just gives the person kind of a snapshot of what you are looking for, what you have done. Make sure that your cover letter is tailored to the job that you are looking for. Okay. And then after the interview, you want to do the same day, you want to do a handwritten, or you can do an email thank you that just gives some highlights from the interview, and then you want to mention the date that you're going to follow up, right? So if they told you that they're interviewing through the rest of the week and they'll be done by Friday afternoon, like, hey, I'll reach back out Monday morning, whatever it is, but you want to give a specific date that you will follow up. Again, same thing. Proper grammar, no spelling errors. Make sure that you're using a professional formatted letter when you are writing your emails. You want to try to look as, maintain professionalism as much as possible. And you want that to be portrayed as much as possible as well. All right, so I apologize, I went over. But does anybody have any questions?
Yeah. Do you have a Kahoot for this third
I
exam?
do not have a Kahoot. I wasn't sure if one was posted. I'm not sure if
I didn't see one that was posted.
you don't see one that's posted. I'll ask. I will see if there's one.
With the resume, the font needs to be between 10 and 12, right?
10 and
Correct.
14.
12 and 14.
Okay, 10 and 14. Gotcha.
12 and 14.
Oh, 12 and 14.
No,
Okay.
the note said 10 and 4.
Yeah,
10
the
and
note
10 to
said 10 and
14. I'm
14. Yeah.
sorry.
Okay.
10 to 14.
yeah,
10 and 14. Okay.
10 to 14.
What other questions?
That's it for me. Thank you.
Yeah, me too.
That's it
Roy,
for
do you have
me.
any other questions?
No, ma'am.
Right. Kaylee, any other questions?
No, and thank you for your time.
Absolutely. Grace, any other questions?
No,
All right.
You guys have
Ernestine?
a good night.
you too.
All right, you
Thanks.
too.
You too.
I don't have any question, but I'm
Okay.
just sitting here looking at you, trying to borrow your brain. I wish I
You
had
want to
that
borrow it? You can have it.
for the exam. Thank you so much.